How many of you have either been to the emergency room as a patient, or friends or family, or just because you had to drop by there? We'll say in the last 2 or 3 months or so. Okay, so probably half a dozen folks here. And of those, was it how many would say that it was a efficient, pleasant, professional experience? Oh, 2 or 3, half of you. I think that's pretty good, actually. Because in California these days, most people would say that it's not. And I love the way Pam Cohn set up this whole talk, because she talked about what ought to be. And the law is what ought to be. And we're going to get into a little bit about the constructive denial of some of these rights vis-a-vis overwhelming of services, overcrowding, the difficulty in always living up to the letter of the law. So with that, we'll go ahead and get started here. So you heard about EMTALA, Emergency Medicine Treatment and Labor Act. It basically, there's nothing in law that says emergency care is an essential public service, but really EMTALA makes emergency care a public trust. When the law requires that care for all persons, notice not all citizens, not all persons of any particular ethnic background, etc., who come to the ED regardless of ability to pay, and that's in Medicare participating hospitals. And if you don't take Medicare, you might as well not be in the hospital business. So it pretty much covers all of the acute care hospitals in the United States. There are a few, like specialty hospitals and stuff like that, who are learning how to skirt around it a little bit. And we worry about that being the case for some psychiatric hospitals, among other specialty hospitals. But this law is basically America's right to health care. If you can think of any other place where you always have access with no delay, no disparate treatment, there isn't any. So, I mean, we don't have national health insurance. We don't have like a lot of countries do. We don't have a right to care in general, but we have a right to emergency care. So this has become America's largest health care program. It's bigger than Medicare, bigger than Medicaid. Some would say it's bigger than all of them put together. It just doesn't happen to have a funding source. So it's an unfunded mandate. And the three elements that Pam mentioned are that we have to provide a medical screening exam to determine the presence or absence of an emergency medical condition. We have to stabilize an emergency if it exists. And we have to provide appropriate transfer to a higher level of care if we don't have the capability to stabilize the emergency in the initial setting. So to transfer patients to higher level hospitals and referral settings. So and that of course also has the inverse, which is that hospitals with a higher level of capability are required to receive transfer from hospitals that don't have that. So this law has a lot of acronyms. It's been referred to as the anti-dumping law, and hospitals with a higher level of care that don't accept your patient, that have the capacity, have the capability, but don't accept your patient, that would be called reverse dumping. And it has a lot of enforcement teeth. It has its various share of $50,000 fines for hospitals and individuals. They can take away your Medicare ticket. That's the ultimate. So there's a lot of teeth in this thing, and And there are mandatory reporting requirements for when a on-call consultant doesn't come in. There's mandatory reporting requirements for a hospital that receives a transfer that wasn't appropriately cared for from the transferring facility, et cetera. So this kind of governs emergency medicine, and we live and breathe this thing all the time. Dr. Sklar.
Does every hospital have to have an emergency room, or can a hospital close its emergency room if it chooses to?
Well, that's a great question, and the answer is no, you don't have to have an emergency room, but the thing and many have closed, and including 9 in the Los Angeles area just in the last year or so, and many have downgraded their services. And some, for a while, there was kind of a loophole where hospitals were downgrading from a basic emergency 24/7 with an emergency doc on duty to a standby, which standby was constructed basically for rural. So they've downgraded, some of them have downgraded their services. There's been a lot of heat in the legislature about trying to keep the services afloat. And obviously a lot of this is financial and has to do with the politics of HMOs and the politics of demographics of various urban versus, some hospitals have much better payer mix than others. And you got this huge weight of mandate, including the seismic compliance law for the hospitals now. You've got their EMTALA burden. The reason they keep their emergency departments open from a purely economic point of view is because most of the not-for-profits use the uncompensated care as a write-off for their charity care, and they have to show a certain standard of writing off their charity care to be able to maintain not-for-profit status. And the for-profits are all trying to crowd into the good payer mix areas and so forth. So it's a huge, emergency care is, you have some systems that are much healthier than others and some that don't have as much of an emergency care burden. For example, Kaiser doesn't have as much of an emergency care burden. So emergency care is kind of a flashpoint for the differential burdens that hospitals have to take and so forth, and it's become there have been a lot of closures, and we're worried about trying to keep the system up and running. Stephen.
Dr. Johnson, for those hospitals that do have an emergency room but don't offer psychiatric treatment, what does EMTALA or similar statutes require? For example, would they have to have a psychiatrist on call and a system to stabilize the patient or transport, or are they just relieved from that? In other words, if they just say, we don't have a psych department here.
Yeah, I would say that every emergency room is a psych emergency room because of the patient volume and frequency of the kinds of things we see. So there has to be a certain level of entry competence. I believe the gentleman who just went up the stairs was saying, well, the non-psychiatrists aren't competent. Well, emergency physicians have to train and have to be able to recognize psychiatric emergencies. And when we get to Lanterman, Petrus, Short, we deal with those issues on a very frequent basis. Now, do we have to have psychiatrists on call? No. Hospitals, Title 22 says that you have to have access to psychiatric consultation for basic emergency services or comprehensive emergency services. There are about 340 basics and about 9 comprehensives in California. There used to be about 100 more basics, and we've seen that number decline substantially in the last decade. But as far as their call requirements, no, you don't have to have psychiatrists on call, but you have to have access to mobile crisis kinds of psychiatric consultation services, usually sponsored by counties or sponsored within the hospital's own private system. So again, what we have now from this unfunded mandate is massive overcrowding and largely gridlocked services. And people have to wait a long time. They perceive poor service because they're constantly being put back for the sicker patients. And in essence, it becomes a constructive denial of access and an empty promise. And this is something that we're always working on socially and politically to try and figure out how to become more efficient. A huge wave of effort to provide services more efficiently, to segment services to have many hospitals, for example, have psychiatric evaluation rooms in the ED or a holding area in the ED, specially staffed. The larger EDs have that. We have certain standards in terms of how patients who are on 5150 holds, danger to self or others, where we put them, they have to be very close to the nurse's station so that we can maintain a reasonable and constant observation at all times. And that's along with all the other patients who have to be close to the nurse's station because they need close observation as well. So there are many competing demands. Mode of arrival, most people think of it as the 911 system, but the 911 is starting to get pretty gridlocked, and so we find higher and higher levels of acuity coming in by private car and walking into the emergency department. Under EMTALA, basically you have to provide emergency care to everyone who makes a request for care or for whom a request is made on their behalf. And when a private car dumps off a trauma patient with a stab wound or something, we consider that a request for care. So then oftentimes we get a lot of police cases. It tends to be a substation for the local police force. And a lot of our 5150 cases come in vis-a-vis psych detention for all kinds of ways of getting in trouble. Whether it's, I had a patient the other night who was depressed, situational thing, problems with his girlfriend, yelling, screaming in the shower. Now Davis has a noise ordinance, and one woman got arrested for snoring too loud. I don't know if you saw that on CNN or something, but in this case, the gentleman was yelling in the shower and very distraught, and when the police arrived, he appeared distraught, and they put a 5150 on him. Now, under my value, I have 5150 authority in my county, all physicians do, and I quickly reversed that after I talked to him and realized that he was just upset. But it's amazing. I mean, they have a pretty low threshold for placing 5150 because in general they're going to get in a lot more trouble when they miss something than when they don't miss something. And so there has to be a good working relationship between the folks who are responding to these situations in the field to try and get as much history as you can, find out exactly what happened, find out what was said, find out who made the report in the first place and how these things came about in the first place to get a real sense of what's going on, because when the immediate crisis is worn off and the person just wants out of there, they may not be giving you the whole story. And so you really have to get that from multiple sources, from friends and family, from the police department, from anyone who can give that to you, in addition to taking a careful interview from the patient and accessing the prior medical records. And we access prior medical records. HIPAA allows us to access prior medical records with consent from the patient from all kinds of sources. And so we'll get fax records from throughout the United States whenever we can, and they're very helpful and very necessary in many instances in order to help us make decisions. So when you get to the ER, I was told that this talk would be about triage, and I think triage is sorting in a much broader sense. But I'm going to talk about ED triage for a minute, which is the specific step in the ER. It's step number 1 when patients come to the ER. If you come in by ambulance, you get brought straight back to a bed, but we may send you out to triage if you're not as sick as the patients who are already standing in the queuing in the waiting room. And triage is where you see the nurse for a quick determination of priority for physician exam and treatment. And usually it's a chief complaint, it's a brief history, vital signs, focus check by trained RNs who are on duty specifically to do triage. And these people are tough, and they're sharp, and they can pick out information very rapidly and basically categorize, prioritize need within a few seconds to a couple of minutes, and they do, and you know, we also use pulse ox and certain glucometry, certain first aid interventions that they're going to do there. And if you're sick, real sick, you get routed straight into the ER. If you have a high level acuity, we use a 5-tier system. Fives are crisis, 4s are immediates, and they get routed back right away. If you're a 3, 2, or a 1, you may go through a desktop registration process while you're queuing for a bed. And basically, everyone has a triage number, and those numbers float if there's a change. And they also have to reassess people who've been waiting a long time in the emergency room because their condition can change. Maybe they came in with chest pain 3 hours ago, and now they've developed chest pain in the ER again. And one of the worst things in the world is we don't want you dying in the waiting room. If you're going to die, please die in a respectable gurney, not in the waiting room. Okay, so again, you're subject to a queue and to, believe it or not, a relatively scientific process. You could theoretically categorize all the chief complaints and write a book about severity and do a Dewey Decimal System, and I could give every one of you a particular categorization, and it would be a very complicated book about all of the different reasons that people come to the emergency room and all the degrees of severity and how serious is their pain and whatever their issue is. And psychiatric disorders would fill a substantial portion of that book. There was a question, and I need to break for that. Sir.
Thank you for reversing a decision on the 5150 on the client. So you got a high five on that one. I am very afraid of the police. I'm a person of color, so that adds an extra burden. And I'm also not 5150, but my biggest fear is how do you reach, is our police agencies somehow learning about it, more about mental health, and rather than just assuming and just taking them away or just ushering them into the to psychiatric wards, or are they licensed professionals, or are we just you are a licensed medical professional, but police officers, the minimum qualifications is just a GED. That's from the highway patrol's qualifications. So what am I getting at? I guess my question is, are we doing is your agency or is anybody here making police departments accountable to be sensitive toward 5150s or people like myself with mental disabilities. So I'm not sure if I make.
No, I
making any
think it's a
sense.
great question because
Okay.
what we're really talking about here is how do people, this is all about access. And this question is exactly how people access the system. And many come in, and I think the answer to that question is that there's a huge variation in quality, like there is in all walks of life. And I mean, I'm very proud of the police department in my hometown. I don't think they miss very often. And I think this one particular case, I can understand, he was probably a lot more distraught at home than he was in the ER. And I wasn't there. And it's difficult for me to second guess those kinds of decisions all the time. But I think that there's a certain amount of the placement of trust within the system, that there are checks and balances along the way, and that I think they got a really tough job. Because what about the patient that they miss on in the other direction, and they leave them there, and they wind up with a mortality on their hands? And gee, the police were there and they didn't do anything. Which would you rather be accused of? Over response or neglect, negligence? It's not an easy call, and I think they make it. At least the cops I work with make the right call the vast majority of the time.
There's been a lot more attention to this recently in terms of the Americans with Disabilities Act, requiring that police be trained to recognize and accommodate people's both mental and physical disabilities. And so I just wrote an article about this that's going to be published soon, and there's been a lot more attention to it. There have been some court cases recently that require that police departments train their policemen to recognize hidden disabilities and know what to do about them so that they don't end up either 5150ing or arresting or shooting, exactly, people because they mistake a psychiatric disability for aggressive behavior or hostility. And so that's another factor in this.
My question is really along the same line, and it relates to assessment by the staff. In other words, the police are out of it, the patients at the emergency room or other part of the hospital, and there is at a minimum a dual diagnosis, psychiatric disorders. Let's just say someone just says, I can't take it anymore, I want to die. And it's migraine headaches, plus maybe it's a major or a major depressive episode. In a proper assessment, which is what we're part of what we're talking about, is how do you assess? Do you see any need for more training with the ER or ED staff in terms of recognizing or just educating on assessing mental impairments it's the next step, I guess. There's the police, but once the patient gets for a medical assessment, do you think that that's problematic or not?
Well, it's always problematic to get enough information to make good decisions. We get, I think Pamela's answer with regard to folks with mental disabilities generally have more help. They have more family members there. I mean, we rely a tremendous amount on friends and family. And so my antenna goes up on the poor souls who are much more isolated and who may not be able to advocate as well for themselves. and I think that's the same with our nurses and so forth, that there's a recognition that patients impaired may not be able to give you the information. I mean, language is a huge issue for us. And, we use phone interpreters. When was the last time you tried to get an emotional nuance through a phone interpreter? And, we're not supposed to use kids. And, but the kids, often tell you what's going on, what's really going on. So I think the answer is that you have to use all your faculties, and you have to be very sensitive. Why there's oftentimes, we talk about ED triage. One of the common kinds of things is that the nurse comes in and says, I can't figure out why Mr. So-and-so is here. I mean, he gave me this song and dance about this, and then he said he's got a headache, and then he's got, hasn't been able to eat very well lately. But there's no emergency. Well, of course, he's in triage for 30 seconds or a minute, and that's all the information that they were able to extract, and there's a whole bunch of people in line waiting for the triage room, and it's uncomfortable saying much more. And so you've got to get that patient back into a private room, and you have to sit down and try and establish rapport and eye contact and find out why the patient's really here. And it's obviously, it a lot of times has nothing to do with the chief complaint that was reflected at triage. So a lot of it is about setting to be able to get adequate information. And I think your question is well taken. How do you, under EMTALA, this is called the screening exam. How do you really establish whether or not there's a psychiatric emergency going on, whether or not this patient is either short-term or imminent danger to self or others, or may still need care and referral because there are longer-term issues going on. So, registration. At registration, they take your basic demographics. They can ask you for your insurance card. They get general consent for emergency treatment, and this is a very general form of consent signed on a piece of paper. The HMO in California is required to pay unless the patient should have known that their condition is not an emergency. That's under the Knox-Keene Act. Lately, the insurance companies have tried to skirt around that and get licensed under the Department of Insurance, where they don't have that same, it's not a Knox-Keene statute. So we've got to pass another law for that deal, because I was proud to say that we killed that wicked witch of prior authorization. Prior authorization is disallowed. We killed that back in 1998 under EMTALA with a special advisory bulletin because patients were being coerced into not obtaining care through this prior insurance authorization phone call, Mother May I phone call to the high school graduate in Oxnard or Kansas City. So, and they're still trying to do it, but it's a constant battle. We won this battle for access, by the way. Haven't won the war on reimbursement, but we won that battle for access. So prices are not allowed to be posted under EMTALA. You may want to know the price, and people have a lot of grievances about this. I want to know what it's going to cost me. Sorry, sir, we're not allowed to tell you. You can talk to the doctor maybe after your screening exam has been provided, and maybe they'll tell you what's necessary, but it's got to be kicked to a higher level of authority to answer those kinds of questions. And you've gone through triage. Now you could withdraw voluntarily. You could decide, oh, I'm not as sick as I thought I was. I've been waiting too long. I want to go home. And we're required to give you an informed refusal. Well, it's kind of hard to give an informed refusal unless you know, unless you've done an exam and figured out why you're there in the first place. But we do the best we can based on triage category.
You're saying that once a person is signed in, they can't just get up and... Once a person is signed in, they just can't get up and walk out the door
Well, it's a free
I mean,
country.
they can, but
They can walk
they're
out anytime they want
supposed
to,
to
but we've got to offer
sign a
them informed
refusal.
information to be able to make a decision about refusing care. That's our obligation.
That's once they've made the first contact with the
Yeah.
staff.
Yes. So now we're talking about the screening exam, and we've delved into it a little bit in terms of getting an adequate history. We've got to decide if an emergency exists. And the basics of a psychiatric emergency are danger to self and others. You heard about gravely disabled, and that comes up now and then. But it often also comes up in a mixed medical context. A person's dehydrated, they haven't been eating, they may have any number of other things going. Maybe they're confused, they're walking out into traffic or something like that. It really really does come up, but not nearly as common as danger to self is about 90% of the issues. Rarely are people striking out against others. I've had a few throwing ashtrays in intersections and things like that, post-amphetamine psychosis and lashing out at other folks. But the vast majority are danger to self, either threatening or have taken an overdose, often brought in by family, often adolescents. Often, I don't see things very much as dual diagnosis. I see people that are drunk, and I see people that are that I have to hold for very long periods of time until I can get them sober enough to even evaluate them psychiatrically. And that presents a logistical problem, and I'll get into that in a minute. But the screening exam is physician-driven. It's a process that includes all the laboratory testing that may be necessary, consultations that may be necessary to decide if they have an emergency. Must be uniform, must be reasonably calculated to determine if they have an emergency. Notice the word reasonable keeps popping up in the law. EMTALA obligation ends if no emergency exists. So once we decide, I may have a treatment obligation under a basic doctor-patient relationship medical standards, under common law standards, but that EMTALA law stops as soon as, and let's say as soon as I determine that your sore throat is not a peritonsillar abscess or an epiglottitis or something that's going to kill you, okay? It's no longer an emergency, and technically I don't have to treat your sore throat under EMTALA. So, screening exam, a lot of people are confused about that word because it's a misnomer. It's not just an eyeball the patient. This is a major evaluation in most patients. You come in with the worst headache of your life, and I have to do a full exam, CT scan, lumbar puncture to make sure that your spinal fluid is clear, that you didn't bleed inside your head. And I wind up telling you to take 2 aspirin, call me in the morning. That's a screening exam, okay? All except for the 2 aspirin part. So, screening exam may be taking the patient to the OR for an appendectomy to find out, in fact, they had an inflamed appendix. So, consent. And Pamela covered this much better than I intend to, but obviously, under EMTALA, there's implied consent under an emergency doctrine for everyone who presents to the emergency department, including all age groups and all situations of diminished capacity, where we're required to see you, required to do a screening exam, required to provide stabilizing treatment for the emergency that supersedes all other consent requirements, whether state statutes or whatever. it basically makes all the other consent issues moot, because under its emergency doctrine, we have to treat the emergency. Now, as she so cogently pointed out, but you have to stop. As soon as that emergency is stabilized, as soon as you've sewn up that bleeding leg, you have to then turn around and figure out, why the person got that thing in the first place, and whether or not there's a psychiatric emergency going on as well. And maybe this was a patient who got that because he was a danger to himself. It was involved in severe risk-taking behavior or self-mutilation, or Lord knows what's going on. But you have to measure each step of the way to decide whether or not what emergency you're treating now, if any. And then once that emergency is stabilized, then consent reverts back to normal consent law. Now, a person can refuse care if they have capacity, and they could technically refuse emergency treatment if they have capacity. We can't force treatment on people. And the classic example of that is someone who takes a Tylenol overdose. Now, Tylenol, that's nothing, right? It's the worst overdose in the world, because it kills you, it burns up your liver in about 72 hours. And so somebody takes a huge bottle of extra strength Tylenol. Under emergency doctrine, I'm going to pump out their stomach or give them Ipecac and make them vomit, and then put down that first dose of antidote. But what about after that's all settled down, and there's a time window now where the person may or may not be depressed, and they still want to die? Do we have a right to force continuing treatment on that person to save them from this painful death of burning out their liver? And the fact is, no. Under emergency doctrine, we can't exercise emergency doctrine 72 hours later and force treatment on that person. So there is an example of autonomy. Now, it's very difficult when you've got a language barrier, and when you've got to somehow arrive at an understanding. Hey, you're just not going to fade away and die a nice peaceful death. You're going to wind up with a terribly painful death, with tubes coming out of every orifice, unless you refuse all such treatment, and the prospect of a liver transplant. So I've actually been in that situation where I had, and it's not me, it's the docs in the ICU, having to talk through a patient to some form of logic, and whether or not they have capacity for logic, and after you get through the language barrier with the Afghani woman or whoever, to get to the point where they can make an informed decision about that. So that's not an easy process, and the emergency department is a very chaotic place to do all that process, and that's why they give us a pretty good latitude with respect to this paternalistic decision making. Now,
Dr. Johnson, if I
Yes.
can just ask, if an individual wants to refuse treatment because he or she wants to die, and the emergency rules don't impose no obligation to prevent that, how would you just? I assume that there first must be a mental status examination in order to abide by that individual's decision to refuse treatment, even though it's going to be fatal. And I just wonder if you can state what, in the emergency room, there's not necessarily mental health professionals. What obligation is there, and to what extent is the mental status examination done in these situations?
Well, you do the best you can under the circumstances, and you do a mini mental status exam on everybody that presents with a psychiatric emergency, because competence is going to become important and capacity is going to become important for decision making. But so that's a ground rule for all psychiatric cases, is a mini mental status exam and certain standard laboratory tests. We always, the psych evaluation folks, the consultants that with mobile crisis or whatever the county has in place, always require a urine tox screen. Frankly, I think it's overkill. I don't think it's necessary, but they always want a tox screen. If there's any indication of alcohol, they always want a blood alcohol. They want a urine pregnancy test on females of childbearing age. And a lot of these are medical legal. They want to try and reduce their risks and make sure that we're not missing anything. Now, frankly, and we're going to talk now about Pamela. Go ahead, please.
There's just, I think we're getting to the line here between emergency care and 5150.
Right.
Once you have someone who presents a psychiatric emergency, if it's just a psychiatric emergency, then they should be 5150. If it's the gash in the leg situation where there's a medical emergency, then of course you stabilize that. Or the overdose situation, you pump the stomach, and then it's no longer a medical emergency. It's now a question of whether you're going to 5150 someone. If the person is still suicidal, then it may be a 5150 situation. And so you no longer have the authority to presume consent under the emergency doctrine, then that's where 5150 comes in. And there are all sorts of due process protections for people who are in the LPS 5150 process that are important, which is why that process exists the way it does. So that's when that starts. The other thing I just wanted to point out about informed consent, just to clarify, I think this is what you said, but even under the emergency doctrine is an exception to the informed consent rules that do apply to emergency rooms. So you still have to get informed consent when you can. I think the trick is that if someone appears to be incompetent, then consent to emergency treatment is presumed. But it's not, I don't want people to think that because it's an emergency room or emergency department, there's no need to seek informed consent.
Right. Where it comes up a lot, though, is the misunderstanding that, say, when a teenager or a minor comes in for an emergency, the presumption that we have to get parental consent, get surrogate consent in every instance to treat an emergency. No. In fact, that would be violating the law to delay emergency screening and treatment in order to wait for that consent. So it's kind of the inverse of the situation that you need to understand also. Now, the whole issue of privacy and confidentiality, that we have to maintain the confidential doctor-patient relationship. We have to get the patient's consent to disclose any protected health information now. And that's always been the case, but except to a conservator who has definite decision-making capacity for that, authority for that person. And so this has become a real problem for families, because we rely so much on families to get information, but we can't give information back to you. What kind of a deal is that? You know, or you're a parent or a relative who's in desperate need for knowing what's going to, if, you know, my son's been missing for 3 days, is he in your emergency room? We can, we can't even answer that question. We have to get the person to answer that question. That it is when they're in the hospital, but that's all we can disclose. We can't disclose.
You can say your son's in the emergency room.
Yeah.
What's wrong with him? Can't tell you.
That's right. That's all we can disclose. He can consent to that information, but here again we're talking about situations of diminished capacity, involuntary, et cetera, et cetera. And so this is, HIPAA, as wonderful as it is to protect all of our privacy, I don't think people have realized what they've lost in terms of the ability to make common sense kind of communication back and forth between each other. So I find myself breaking this law from time to time because it's just not right. It's just not reasonable not to tell a mother more information about her child who's in the emergency department.
Yes, I would like to. I'm with the Office for Civil Rights of Health and Human Services. I was the HIPAA privacy specialist for Region 9 until February of this year, and you're not violating the law. HIPAA says that you should make a concerted effort to find out that you're only disclosing information to a person like a family member. And you, of course, you wouldn't disclose if there is some kind of note of protection or anything in place, but you are allowed to discuss within limits. You're the healthcare professional. You certainly are allowed to tell patients, family members, if they're calling, where the patient is. Again, to some extent, and you are the healthcare professional, if they're completely incapacitated, you may need to tell them more than if the person just needs emergency treatment, so then the person can consent later on. So certainly you're not breaking, HIPAA as it is just by telling, family members and or friends. It could be friends, it could be neighbors. It depends on what kind of a support system they have. So.
But what's changed is that we have to be much more scrupulous about getting patients' consent to give more than we were in the past, because this thing has teeth now, and so substantial teeth, and so we have to make sure. I mean, the patient may be off an X-ray somewhere, and maybe I have to wait till they get back before I can before I can disclose this information, et cetera.
Right.
And I can't take it upon myself. And yeah, you've got to identify that is the family member, et cetera, et cetera. And so it's just not as free flowing, I guess I might say, as it used to be. And it is problematic for families.
Well, you're in the emergency business, and HIPAA provides for emergencies. And so, again, if the person is of sound, the patient is of sound mind, they can, make some kind, informed consent. It wouldn't apply. But again, we're talking emergency situations, and what I did is I intervened a lot of times because hospitals wouldn't give out any information. I mean, I called overseas. I had families in the military. They found out that the mother was in the hospital as an emergency, and nobody would give them any information whatsoever. They faxed a healthcare power of attorneys. They faxed driver's licenses, anything to, try to prove who they were, and the hospital still wouldn't give them the information.
This was a terrible problem for you.
Yeah.
Getting
as I said,
hospitals up to
because
speed.
the hospital, the healthcare community has went too far to the extreme. Again, this was a law to protect privacy of patients, but not to impede healthcare. And as part of healthcare, part of that is to to notify, family members, support systems, that kind of thing. So again, as I said, I think there is a huge myth out there that I've been trying to fight for the last 3 years. But, and so, as I said, again, you won't be violating, HIPAA if you're just, notifying family members. As long as you make an effort that you're not disclosing anything. Again, somebody's HIV status would be different. Those kinds of things, and I understand there are additional laws under, California, additional laws of protection in terms of consent. But to tell somebody, we have your father or your child in the emergency room, would you come down here? That's not disclosing anything. That's not a violation of HIPAA.
But recognize, of course, that these reasons for being in the emergency room, what we're talking about today, are among the most private reasons people would want to have.
That's true, but again, the people deserve a right to, for the most part, they would want family members or the support system to know where they are at least. Excuse me. Again, it's within
most of the time, but not always. Pamela?
I think HIPAA does impose barriers on you and also on me as an attorney in terms of giving and receiving information about medical information about my clients. But I think the important thing to know is that in this context, HIPAA is meant to not only make sure that you know that the person that you want to give information to is in fact a family member, but also that that person is really a support person for this individual. And it may well be that the person is, you know, that person could be the reason why the individual's in the hospital. And so I think that one of your obligations is to make sure not only is this person who she says she is, but also to the best of your ability, is this really someone that, assuming the person lacks capacity to, I mean, if the person can give consent, then that the person gives consent. But if you have a question about whether the person can give consent, you want to be really careful about assuming that the patient wants the individual to know anything about them.
There's a lot of situational judgment, as you've heard, with so many of these issues. So, and huge variations in quality of people's ability to do that. So, again, emergency room is a place with a lot of sticky wickets.